session today is talking about advancing health equity through payment innovation. And I'm really pleased to be here today with my colleague, Meghan Elrington-Clayton. We're both from the Center for Medicare and Medicaid Innovation, or the CMS Innovation Center. And we are really pleased to talk about a model that we announced last month called the ACO REACH model that builds in some really interesting perspectives on advancing health equity and things that we're interested in testing out. And so maybe without further ado, I wanted to also give some background on what the CMS Innovation Center is doing. So what I'll do is start out with some basic framing on our new strategy that we announced last October, how the ACO REACH program fits into that strategy, and then the bulk of the presentation is really my colleague who leads the group within CMMI, or the CMS Innovation Center, that's running the model. So really happy to be here. For those who don't know much about the CMS Innovation Center, it was part of the Affordable Care Act, and the act set aside $10 billion every 10 years, that renews every 10 years. And the purpose of the center is to test new payment and delivery system reforms to hopefully reduce program expenditures while preserving or enhancing quality of care. We have 3 scenarios for success. We can improve quality and maintain cost neutral. We can keep quality neutral, but reduce cost, or we can do both. We have models in the area of specific conditions like end-stage renal disease, specific episodes of care like the total hip and knee replacement, specific populations like rural providers, and we also have models in Medicare Advantage and Part D. When I got to the Innovation Center 10 years ago, last year, we looked back, wasn't 10 years ago, looked back and tried to figure out what we've learned from the 54 models that have touched 28 million beneficiaries in the last 2 years and about 528,000 providers. So what have we learned over the last 10 years? And I think basically we learned that hasn't been enough focus on health disparities in Medicaid. We have a lot of models, and sometimes they overlap and create complications for providers. Voluntary models we've found, and maybe no surprise to this smart audience, results in risk selection and doesn't save money. And it also leaves out some providers who may not have the resources to be able to commit to a model. Think about safety nets, for example. And some providers are reluctant or unable to accept downside risk without an inducement or assistance. And again, I think that's where we saw a lack of participation by providers that serve in underserved communities. We had challenges setting some of the appropriate financial benchmarks, and we had found risk adjustment challenges, some of which is addressed by this model. And I think one area also is that the success of models is too narrowly defined. So we have had 4 models that met the statutory standard for expansion. And the statutory standard for expansion is tied to certification, which means the actuary says that with 95% certainty, the model will save money into the future on a net basis. So not a lot of things meet that standard. And so by defining it so narrowly, I think we've missed some of the impact that we've actually had from the models that we've run. And then finally, we've spent a lot of time talking to providers, health systems, plans, but we haven't really talked enough, I think, to patients and beneficiaries, and really trying to get their input and making sure we're reflecting their perspective. So we put out a vision in October. It's on our website if you're interested. We set aside a vision. We set out a vision, which is a health system that achieves equitable outcomes through high quality, affordable, and person-centered care. And we have 5 main strategic objectives, and I'll run through them really quickly. This will all make sense when we get to Meghan, because it'll all seem to fit into this puzzle. First, we've really put a priority on accountable care and really trying to drive accountable care. And that means increasing the number of people in relationships with care providers that are responsible for managing total cost of care and quality. Second is thinking about putting equity at the center of all of our models. Now we are collecting data on race and ethnicity, as well as social determinants in our models. We are making a very deliberate effort to try to recruit safety net providers, FQHCs, rural health providers, and making sure that we have the resources and tools that they need to be able to, including payments, to be able to participate. We're trying to test approaches that close gaps in care and looking at tools and resources that help providers that are participating in models. We are focusing more on patient out-of-pocket costs, so not just program costs, which is in the statute, of course, we aren't ignoring that, but really thinking about the impact on patients' out-of-pocket costs. And then finally, thinking about multi-payer alignment and working with other partners. So that includes commercial payers, purchasers, states, Medicaid programs, and making sure that we're all sort of moving in the same direction. We've also committed to greater transparency and communication. As part of strengthening communication, we're, I think, really, excuse me, trying to work more closely with beneficiaries and advocates. We're trying to do more listening sessions to try to get the word out, to try to communicate with people and get input, and when we can, publish what we're doing very clearly and hopefully speaking to a broader audience. We're also committing to data transparency and trying to share data for researchers and through the mechanism that CMS makes other data on Medicare and Medicaid available, the VRDC, or the Virtual Research Data Center. And then finally, as I mentioned, defining success and really trying to focus on health system transformation and not just this narrow definition of certification. So all of that is to say, if you look at the back of the white paper, we've put out where we're heading and how we're hoping to get there. And you'll see that ACO REACH is really one of the models that we think is part of the strategy that's going to inform what we do and our path forward. It is part of the driving the goal to drive accountable care and really includes some important aspects of advancing health equity, and that's what we're here to talk to you about. So we'll talk about the equity aspects and then also some of the other aspects. And so maybe with that, I'm going to turn it over to my colleague.
Thanks, Liz. Good afternoon, everyone. Thanks so much for joining us today. As Liz said, I'm Meghan Elrington-Clayton. I'm the director of our Division of Financial Risk at the Innovation Center. And I'm really excited to talk with you about the ACO REACH model and really the innovative provisions we've added to that model or including that model to really advance health equity and address the priorities of the administration.
The green button.
Oh, thank you. Yeah, sorry.
I'm going to do it for you.
Oh, sure, sure. This is fine. So just as Liz mentioned, ACOs are an important part of our strategy for CMMI kind of going forward. And as part of that, I wanted to talk a little bit more about really our vision for ACOs and the initiatives that we're planning to do there. So ACOs are really important in terms of bringing providers together to really focus on person-centered care, looking to total person care for their aligned beneficiaries. And in that way, it's a great opportunity for looking to create equitable outcomes across and high quality care for those beneficiaries. So in accomplish this goal, we really want to partner as we think about our ACO visioning with organizations who really share CMS's vision and values for improving patient care. So in thinking about our ACO initiatives, we really want to focus on 3 key principles. So one is just that we want to make sure that our beneficiaries in Medicare, traditional Medicare, retain all of their rights. That includes the ability and the freedom of choice to see any of their Medicare enrolled providers and suppliers. Second, we really want to make sure that we're promoting greater equity in the delivery of health, high quality services, and make sure that our models are testing our ability to do that. And the third is we really are looking to have our models extend their reach into underserved communities to really improve access to services and quality outcomes. And ACO REACH really strives to address those 3 principles. In terms of ACO models, ACO REACH is really a 3rd generation ACO model. As you probably are aware, CMS has the permanent ACO program, the Medicare Shared Savings program that was created under the ACA. Our ACO models are intended to really inform and test strategies to speak to and help update and refine the Medicare Shared Savings programs. And ACOs are really intended to align financial incentives across the providers and provide tools to support groups of healthcare providers to better coordinate care for their Medicare fee-for-service beneficiaries, with the outcome of really improving quality and reducing cost. And our goals in terms of the specific ACO portfolio is really to make sure that we're helping to catalyze the partnerships between the healthcare providers, also that we're enhancing risk-sharing arrangements with ACOs so that both CMS and the ACOs share in savings generated by their efforts. That's been a challenge in the past with some of our ACO models. Also, we want to really provide and increase the number of tools and flexibilities we have available to allow those groups of providers to really better serve their beneficiaries and support patient engagement. And of course, as Liz mentioned earlier, as our broader strategy, we want to really increase the participation in ACOs overall. So what is ACO REACH? We've been talking for a few minutes and haven't really talked about what that model really is. And so, as I mentioned, the third generation ACO model, it's a redesign of the Global and Professional Direct Contracting Model, or GPDC. And it's basically been redesigned to really reflect the priorities of the administration and to address a lot of the stakeholder feedback that we received. And so we're looking at ACO, of bringing together groups of providers to create ACOs, but really making sure we're focusing on equity, that we're reaching the underserved. We're making sure there's level playing fields in terms of new entities or participants coming into the ACO space, and also making sure that we are addressing concerns around risk adjustment and appropriate payment. As a time-limited model test, ACO REACH is really intended to, as I mentioned, inform the Medicare Shared Savings Program, as well as future models with a focus really on health equity, healthcare provider leadership, and beneficiary voice in model participant decisions, as well as robust participant screening, monitoring, and transparency. So we want to make sure that folks understand what the model's doing and achieving, that beneficiaries and providers have a strong voice in the direction of the ACO models in terms of their governance. The model the GPDC model will transition to ACO REACH on January 1st, 2023, and then the ACO REACH model will continue through 2026. We're currently accepting applications for our cohort to begin January 2023, a new cohort into ACO REACH, and that application period is going to end on April 22nd of 2022. So briefly, just in terms of the model's goals, in terms of the transition and realigning the model with the goals of the administration, the models for the goal have actually shifted in focus with regards and focus really on three primary goals. One is health equity, as we mentioned earlier, and addressing disparities in underserved communities. The second is really continuing the momentum of provider-led organizations participating in risk-based models. We've heard a lot of concern about potentially for-profits and insurers participating in this space. We want to make sure that providers continue to lead the way in caring for beneficiaries and coordinating care under ACO models. The third is also protecting beneficiaries in the model. And there we want to really focus on making sure we have the right folks participating in the model, that we are monitoring the impact on our beneficiaries, and also making sure that we're providing greater transparency to get feedback from our stakeholders on the progress of the model and its performance. The ACO REACH model, as I mentioned, brings together groups of providers as ACOs to really coordinate care and take on financial risk for the total cost of care for their aligned beneficiaries. And under ACO REACH, there are two model risk options, same as we would have under the Global and Professional Direct Contracting, so I won't spend too much time on that. One is the professional risk option, in which the REACH ACOs take on 50% shared risk with CMS, and also take on primary care capitation, where they receive capitated payments for the primary care services provided by their aligned providers to their beneficiaries. Under the global risk option, this is the higher risk option where they take on 100% risk. CMS receives a discount off in terms of their benchmarks up front to ensure CMS gets a share of their savings, but after that, the ACO takes on full risk. And under that option, they have the ability to participate in either primary care capitation, as I mentioned under professional, or total care capitation, where they receive capitation for 100% of the total cost of care provided by those providers that have contracted with the ACO. Just want to note that for those providers that are still providing services to their beneficiaries but are not necessarily aligned or have an agreement with the ACO, those payments would still go through Medicare fee-for-service payment. All right. So, as part of our goal to really make sure that we are protecting our beneficiaries, we really thoughtful about what does this model mean for beneficiaries and what are we doing to protect them. And so beneficiaries in ACO REACH remain in traditional Medicare. We know there's been some questions about that, but they are traditional Medicare, and consistent with that, they have access to all their normal Medicare benefits, as well as access to all of their Medicare eligible and Medicare enrolled providers. So there are no restricted networks or any prior pre-authorization or anything similar to that we may see in some of our other programs like Medicare Advantage. However, beneficiaries whose primary care provider is part of a REACH ACO, we expect to see that they're going to feel and see improvements in the quality of care that they are getting. And this is due to greater clinical support and care coordination. In addition, ACOs may offer enhancements to their Medicare coverage, referred to as benefit enhancements, that really provide greater access to things such as home-based care and also concurrent curative care while in hospice. There are other services that a REACH ACO may offer to encourage beneficiary engagement in their care, referred to as beneficiary engagement incentives. And also beneficiaries are just notified annually about their alignment to a REACH ACO so that they are aware of what's available to them. But they're not necessarily required to participate in any of the care coordination or services provided to REACH ACO. So there's still lots of flexibility and full access to the traditional Medicare program under the model. So wanted to talk a little bit about the innovative health equity provisions that we've included in the model that we're really looking to learn from and build upon in the future. ACO REACH includes 5 specific provisions to promote health equity and expand access to underserved communities. The first is really a health equity plan. So each REACH ACO starting in 2023 will be required to develop and implement a health equity plan. And really in that plan, they're going to identify underserved patients within their beneficiary population and then implement initiatives to measurably reduce health disparities among that population. And that's really built upon the disparities impact statement that the CMS Office of Minor Health put out a few years ago, and we're building upon that to really encourage and require our REACH ACOs to focus on health equity as they think about providing equitable care to their beneficiaries. The second is the health equity benchmark adjustment. And really this is a beneficiary level adjustment that we're making to their benchmarks for those REACH ACOs who serve a higher proportion of underserved beneficiaries. And really the thought here is that traditionally ACOs have have had less presence in lower socioeconomic status regions and in higher proportions of non-white populations. And so we're looking to address some of the disincentives to them entering those populations, which we think in part have to do with the historically suppressed spending levels for those bennies. So the point of that adjustment, which I'll talk about a little bit more, is really to increase their ACO participation in those underserved areas and the alignment of those beneficiaries. The third provision is the health equity data collection requirement. So we're looking to require REACH ACOs to collect and report Benny-reported demographic data and social determinants of health data. And in 2023, we're actually providing a 10% bonus to the quality score for those ACOs for submitting demographic reporting. And that reporting will be based on the United States Core Data for Interoperability version 2, USCDI v2, which includes race, ethnicity, language, gender identity, and sexual orientation. Eventually, we're looking to move to requiring full reporting both demographic and social needs data. For the social needs data, we're looking at the Accountable Health Community Assessment Tool, the North Carolina Assessment Tool, and the Papari Assessment Tool. The third health equity provision that we're implementing under ACO REACH is really the Nurse Practitioner Services Benefit Enhancement. And this benefit enhancement is really intended to reduce the barriers to access in areas with limited access to physicians by allowing nurse practitioners to certify services without requiring collaboration with a provider. So some of the areas there would be hospice care certification, certification of need for diabetic shoes, certification of cardiac rehabilitation care, and others. And then also in our applications, we're really looking to encourage participation by groups with demonstrated direct patient care experience and/or demonstrated successful experience furnishing high quality care to underserved populations. And so consistent with that, we have discrete points in our applications for those providers, those organizations that demonstrate that kind of experience. It is not going to be the sole determination for participation, but will be a factor as we look at their applications. And just want to take a moment to talk a little bit about the health equity benchmark adjustment. We've heard a lot of interest in this adjustment and what we're doing here. And so, again, the issue that we're trying to address here is the potential disincentive for ACOs to serve these beneficiaries due to historically suppressed levels of spending. And so what we're looking to do is really increase the benchmarks for those ACOs that are serving higher proportions of underserved populations so that they'll have more resources to address their needs. This adjustment is budget neutral, so we do have some ACOs that will receive a higher benchmark as a result and others that will have lower. It's a beneficiary level assessment. What we start out by doing is really determining a composite measure to underservice for each beneficiary. And we're doing that looking at the ADI, which is an area level measure of socioeconomic factors, medical disparities, underservice, and then adding to that dual Medicaid status, which is the beneficial level measure that we're applying. We're bringing those together to create a composite score. We're considering other factors as well that we'll provide more information about in the future should we change this, but it would start with those that are, stratifying that list of composite scores for all the beneficiaries aligned in a REACH ACO. And for the top decile, we'll apply a 30 per Betty per month adjustment to the benchmark to the REACH ACOs in which they're aligned. For the bottom 5 decile, we will actually apply a smaller reduction to their benchmark of $6 per Benny per month. And those that are in the middle 4 decile will have no change. And so this is at the Benny level. We think when that comes up to the ACO level, we will have, for those that have a smaller population of beneficiaries who are underserved, the adjustment to the benchmark will be relatively small, but we think for those who have a larger proportion, it will actually result in a meaningful adjustment to their overall benchmark. One other thing we thought would be of interest to share that we're doing under ACO REACH is really the work we're doing around risk score growth constraints. So there's been a lot of concern about how do we address the incentive to increase our risk scores and to continue to report in order to increase payments potentially inappropriately. And so ACO REACH has a couple of provisions to really restrain that growth that in many ways is more restricted than in the Medicare Shared Savings Program and the Medicare Advantage Program. And so we have a 2-step approach after normalization of the risk scores. The first is we apply a symmetric 3% cap on the risk scores relative to each ACO's historical risk scores. This is looking back at a reference period that's 2 years prior, and so there's no more than 3% change over those 2 years. That cap under ACO REACH will be applied after we look at any adjustments to the demographic portion of their risk scores. The other thing with ACO REACH there is that we're also going to apply a static reference year for when we apply that cap starting in 2024 so that we don't have a growth just happening more and more over the period of the model for individual ACOs. The second step is we are applying what we call a coding intensity factor, and that really limits the risk score growth across the entire model back to the national reference population. And so we just applied this factor program-wide across all the ACOs evenly to really protect the model from risk score growth. And between the two, these approaches really help to protect protect Medicare, but also to protect individual participants from inappropriate coding by other participants and not having any unintended consequences there. All right. Just wanted to talk a little bit about the model provisions for some background. So under ACO REACH, again, these are, ACOs similar to our previous models. They're entering into arrangements with CMS to take on financial risk and taking on accountability in order to provide, the coordinate care for our Medicare fee-for-service beneficiaries. Under ACO REACH, we have 3 types of ACOs that we offer: standard ACOs, new entrant ACOs, and high needs population ACOs. Standard ACOs really look like our traditional ACOs who have, perhaps previously participated in the next generation ACO model or the Medicare Shared Savings Program. And so they have experience serving beneficiaries in traditional Medicare program, and they are experienced taking on risk for those beneficiaries. And for those folks, there's a minimum of 5,000 aligned beneficiaries that they have to participate in the program. And they receive a benchmark that's really a blend of their regional expenditures as long as historical expenditures. New entrant ACOs, which is unique to ACO REACH, these are participants that have not traditionally provided services to Medicare fee-for-service beneficiaries and taken on risk for those benefits. So they may have experience perhaps serving beneficiaries in Medicare but not taking on risk, or maybe perhaps not in Medicare fee-for-service. These ACOs, for their participant providers, no more than 50% of them can have prior experience in one of our essentially APM programs, so whether it was NextGen or the Kidney Care Choices model or similar. In addition, these ACOs rely a little more heavily on voluntary alignment because they have less history in this space. They have a glide path in terms of their beneficiary alignment. They have to have a minimum of 2,000 beneficiaries in 2023, and that goes up until 5,000 by the end of the model. And the third track is high needs population ACOs. And these are really ACOs that focus on beneficiaries with complex needs who are really employing some of the care delivery strategies that you would find in the PACE program under Medicare Advantage. So these are typically smaller organizations that are really experienced with coordinating care for these beneficiaries who, have potentially high risk scores, are frail, or have other significant chronic or serious illness. And for these ACOs, we have employed a concurrent risk adjustment model that really looks at their conditions during the performance year in terms of determining their risk scores. In addition, we have a glide path where they start at 500 minimum number of beneficiaries in 2023, and that goes up to 1,400 by the end of the model. All right, and just for reference, REACH ACOs, they're really defined as a legal entity that's identified by TIN, similar to what you would find in Medicare Shared Savings Program. They contract with us to participate in the model. Again, we're looking to really encourage those with direct patient care experience or a strong record serving underserved communities to participate as REACH ACOs. They have to be able to not only share savings and losses with CMS, but to administer payments to participant providers, because again, under the model, they have to take on capitation for their participating providers. Great. Key to the participation of REACH ACOs is really their provider relationships. So they have to, they are entering into an arrangement with Medicare enrolled providers and suppliers who agree to participate in the model and agree with their goals. And there's 2 types. One is participant providers who are really, instrumental to the ACO in a number of ways. One is that they are, their patient populations are what feeds into the alignment of beneficiaries to the ACO. We really look at the plurality of primary care services they're providing, and that's what we use to determine for claims-based alignment, which I'll talk about a little bit. Also, they have to enter into the payment arrangements with the ACO around capitated payments reduce and accepting claims reduction in terms of getting payments through the ACO versus through the Medicare fee-for-service payment system. They also are responsible for reporting on quality measures, so in that way they feed into the shared savings achieved by the REACH ACO. And of course, they have the ability to participate in any benefit enhancements or beneficiary engagement incentives that the ACO elects to do. Also, the second type is really preferred providers, who may be specialty providers, providers with which the ACO will have a special relationship. They would still have an arrangement, but those providers are not required to report on quality, and they are not required to accept capitation in order to participate with the ACO, but they can still help further their goals in terms of care coordination. As mentioned earlier, beneficiaries are aligned to REACH ACO in a couple of ways, similar to, this has unchanged from the Global Professional Direct Contracting model, but one is a beneficiary can elect to assign, to designate a primary care provider, participant provider as their primary care provider that's aligned to an ACO, and in that way select a particular ACO. And that can be done either on Medicare.gov electronically or through a paper form that they submit to the ACO. The second is claims-based alignment, in which CMS looks at their claims utilization data and determines where the plurality of their primary care services lie with regards to an ACO and align them based on that. So that way we're making sure that any beneficiary that's aligned to an ACO has a strong relationship with the providers that are working with that ACO. And as usual, to us, beneficiary choice is very important, and so voluntary alignment takes precedence over claims-based alignment in the model. Financial goals and opportunities. Just wanted to do a quick overview of some of the financial features of the model and how they support the model goals. In thinking through our different generations of ACO models, CMS is constantly looking at our benchmarking methodology to make sure that we have the appropriate financial incentives in place, and also to help achieve the goal that Liz mentioned before about us being able to make sure that both the model and both CMS and the ACO are partaking in any shared savings achieved. And so for the ACO REACH model, we're really looking to improve accuracy and stability in the benchmarking methodologies while maintaining simplicity and prospectivity where possible. And so there we have features like a county level rate book that we apply, as well as risk adjustment, coding mitigation, which I spoke to earlier, in order to achieve those goals. We have several novel options here for shifting payment from fee-for-service towards an alternative payment mechanism through value-based care entity. And so that would be our primary care and total care capitation mechanisms that I mentioned earlier. And then there are unique model features that really enable participation by entities that are new to the ACO space and focus on caring for high needs populations. And so that includes having a benchmark that's based initially on regional factors and then moves to incorporate historical expenditures as they gain more experience under the model, and then also applying a concurrent risk adjustment model to support smaller, high-risk populations. And finally, as I mentioned, we have the new health equity benchmark adjustment that I went through earlier to better support those ACOs that are really providing care to underserved communities. Okay. So just briefly, in terms of what we're trying to do here, in terms of our payment mechanisms, again, the goal is to really provide the ACOs with a stable monthly payments directly from CMS, thereby providing improved cash flow and control of funds to providers. And that helps them to make investments to improve the care for their beneficiaries, and then also to develop value-based arrangements directly with downstream providers. And so there's the two mechanisms that I mentioned. There's capitation payments, and then also there's an advanced payments option. Capitation payments are mandatory for those REACH ACOs. They all must select in capitation mechanisms. These mechanisms are not reconciled directly against our actual claims reductions incurred for the performance year. So they are held accountable for that. And then also we have the advanced payments option, which is voluntary. And ACOs are not required to participate in this, but this is also another option for them to improve cash flow. And it closely mirrors the population-based payments that we offered in the next generation ACO model. And those payments are directly reconciled against actual claims when we do reconciliation. I mean, Skip did talk about primary care capitation, total care capitation previously. Reconciliation, we do determine shared savings and shared losses after we compare basically their actual expenditures against the final performance year benchmark. And when we look at actual expenditures, we're looking at both the capitated payments we provided, advance payments, and then fee-for-service claims amounts that we've paid directly to their providers. For those in the global risk option, we apply a discount to the performance year benchmark as the primary mechanism for CMS to obtain savings under that option. We also apply a 2% quality withhold, which is applied to performance year benchmarks to really incentivize quality performance. And with our reconciliation, we have a provisional reconciliation that it's optional, that occurs shortly after the end of the performance year based on 6 months of expenditure, and then the final one, which is done after the end of the performance year and provides sufficient time after the year to fully capture claims processing and all right. And then quickly, just to talk a little bit about the quality performance again, we do apply 2% quality withhold to their financial benchmarks. Those are amounts held at risk that they can earn back based on their quality scores. And in our strategy, we're really focusing on, reducing reporting burden relative to previous ACO models. So we have a much smaller set of quality measures that we use in ACO REACH, let's say compared to the next generation ACO model. We're also focusing on relevant and actionable measures, and also, there we have a provision around continuous improvement and sustained exceptional performance to really provide incentives for that. So the high performance pool, which really encourages them to continue to improve on their quality measures year over year. And in the quality approach, we have measurement tools that include claims-based measures and patient experience measures. So we have 4 claims-based measures. Risk standardized all condition readmission, all cause unplanned admissions for patients with multiple chronic conditions. And then for high needs population ACOs, we have days at home for patients with complex chronic patients. For standard and new entrant ACOs only, we have timely follow-up after acute exacerbations of chronic conditions. And then the patient experience survey, we use the CAP survey for that quality measure as well. All right. I referenced earlier that in taking risk on in our ACO models, we also seek to provide tools and flexibilities to help the ACOs coordinate care for their beneficiaries. And so benefit enhancements and beneficiary engagement incentives are means that we use to do that. And so we have authority under 11 and 15 of the Social Security Act to really conditionally waive certain requirements in order to support that. For benefit enhancements and beneficiary engagement incentives, REACH ACOs have the option and can choose to offer some or none or all of the enhancements that we offer. And to the extent that they choose to participate and offer any of them, they are required to provide an implementation plan for us regarding how they plan to use those provisions. So in terms of just benefit enhancements, these are really conditional waivers of the Medicare fee-for-service payment policies in order to create those flexibilities. And so they're paid through the Medicare Trust Fund by way of the fee-for-service claim processing system. And for ACO REACH, we're offering the same ones that are available under the Global Professional Direct Contracting Model. So around waivers of the 3-day SNF rule, telehealth, several to really enhance access to home-based services, so the post-discharge home visits, care management home visits, and home health-bound waiver benefit enhancements, as well as the concurrent care for beneficiaries like the Medicare hospice benefit. We did add one new one that I mentioned earlier, which is the nurse practitioner services benefit enhancement for starting 2023. For beneficiary engagement incentives, these are really incentives that the ACO elects to provide to encourage their beneficiaries to engage in coordinating their care. And so those are really services paid for by the REACH ACO. They're optional, and throughout the model, these are the same as what were offered in the Global Professional Direct Contracting. They can use this to be really creative in trying to address the broader needs of their beneficiaries beyond what's offered under the Medicare benefits. So there's a chronic disease management reward program. They can also offer to reduce cost sharing for their Part B services, and then they can offer in-kind items or services where we've seen, in the past, ACOs often use these to offer services to really help the beneficiaries engage in their care, such as transportation services or dental services. Okay. And with that, we'll turn to the model timeline. Again, we're currently accepting applications through April 22nd for our new cohort that will begin January 1st, 2023. We're planning to announce those ACOs that are selected in June, and there will be an implementation period offered similar to what we've done under the Global Professional Direct Contracting model, and that will be in August of 2022. And this slide is just providing some resources for getting additional information. I know we talked about a lot of information, and there's a lot more here we have on our website here. So definitely take a look to see more about our request for applications, to see what we've changed in the model in terms of transitioning from Global Professional Direct Contracting to ACO REACH, and just generally what we're trying to accomplish under ACO REACH.
Great. So that is the presentation, and that was hopefully detailed enough, but not too detailed explanation of the program, and we're open for questions if anyone has any. I think there's a couple of mics, or there's probably few enough people. If you shout really loud, we can probably hear you. It's probably a good idea.
I just wanted to clarify, I think you were talking about some of the requirements for the SDOH data collection. What assessments did you say you were, I guess, allowing for use for that?
Sure, let me repeat those for you.
And then the second question is, did you indicate the version of US Core that would also support that as well?
Yes. So yes, for the social needs data reporting, we're looking at the Accountable Health Community AHC assessment tool, the North Carolina assessment tool, and the Prepare assessment tool, P-R-A-P-A-R-E. In terms of the USCDI, we are looking at version 2. We may potentially also accept version 1, but we're primarily looking at version 2 for 2023.
Great, thank you.
No problem.
It's just going.
Oh, that was me.
No, it's not you.
No, it's a long walk.
I know, exactly.
Hi, Larry McNeely with the Primary Care Collaborative, and I just want to praise you all for the work you did under considerable pressure, evolving this model into a place that I think can work well for beneficiaries in the program and the program moving forward. I'm interested in your thoughts on the resources the model provides to accountable entities to manage care across the whole person, to really provide that whole person care, not just the social care, but the idea of integrated services. Obviously, Medicare has some existing ways to do that, and of course they'd be doing that and responsible for their overall cost. But I'm interested in your thinking through any flexibilities in that respect, and maybe if you want to zoom out from this, the things that you might be thinking on to support whole person care across the range of models that the Innovation Center supports. Thanks.
Do you want to answer the first one, and I'll try the second one?
Sure. So yes.
Behavioral health.
Right.
So yes, one is we are looking for our ACOs to really think about the whole beneficiary in terms of the care. And so some of that is, you'll see that in the Health Equity Plan, where we're really looking for them to reach out to community-based organizations and others to take advantage of our benefit enhancements, our beneficiary engagement incentives, to pull together those resources to really address the needs, the other pieces that really affect their ability to achieve optimal health care. And so what we're hoping, and as we go through our learning approaches and talking to stakeholders, is really how can we help Reach ACOs really make those connections, access resources that are available beyond just Medicare to help address the full gamut of care for those beneficiaries. And so between that and additional funding we're providing through the health equity benchmark adjustment, we're hoping that that will really help move the needle in that direction and thinking on a broader scale for their beneficiaries.
And I guess I would add that these are not fully capitated plans, that you have the option of just the primary care capitation or a broader capitation for a broader set of services, but by no means are these fully capitated plans. To your question of how we're thinking about integration of behavioral health and specialty care, we are continuing to look at models that are innovative on the ability to integrate those services. So I think what we won't be doing, I think in the past we have been doing ACOs and primary care models, and then separately a lot of episodes of care and bundled payments, but they sort of sat outside of each other. We're looking at ways of sort of trying to integrate those approaches in the future. I think we're probably less so in this model, looking forward in the future. We do realize we may need to bridge between where we are now and this accountable care world that we're looking at, in which case we may consider, and we are considering whether we might look at targeted bundles, but what we don't want to do is have bundles and episodes that conflict with what we expect from primary care to be able to manage. So we wouldn't do chronic care bundles, for example, because we expect that ACOs and primary care would be managing those conditions. But there might be services, procedures, conditions that primary care and ACOs may need tools and resources to be able to manage. And so that's how we're sort of thinking about it, if that makes sense.
Hi, I'm Jennifer Podelka from Health Management Associates. I also want to thank you for your work on this program and for coming to talk to us about it today. There was an earlier announcement that there might be a cap on the number of new organizations accepted for the January 1, 2023 start date. And I wonder if you have any updates, if that cap might be a total number or by geography or type of ACO model.
I mean, I can answer that, which gets to maybe more of a political question too. There's a lot of, we heard a lot of feedback, some positive, some negative about the program, and some policymakers calling for us to limit the number of providers and participants. At the end of the day, we need to be able to evaluate the model. So as we're making the transition from one model to the other, we weren't sure what was going to happen. Are we going to have organizations drop out? Are we going to have enough to evaluate it? So we need to have enough to evaluate it, and then we also want to make sure that it looks still like a model test and not like a new program. And so we'll see what happens and see how many applicants we get and what happens, the types of applicants we'll get, and we'll consider that after we look at who's applied in April.
Yeah.
Hi, Joe Thompson from Arkansas. Thank you both for being here and for the elegant evolution of value-based payment that this model kind of represents. Mm-hmm. My question is really from a rural perspective. Many of the value-based models, just quite candidly, have not worked and were predictably not going to work because of low density population and provider narrowness of availability. Can you speak to how this model would support that specifically, or more broadly, the thought process within CMMI of how you think about value-based purchasing in the rural healthcare delivery systems in the state?
So first of all, when we say that there's this payment bump for serving underserved populations, we also mean rural. So rural providers enrolling with, partnering with rural providers, serving those areas of the country is part of what constitutes potential bump in payment. In terms of what we're thinking about writ large, we've been working with our colleagues at the Center for Medicare, Dr. Meena Seshmani, and who runs the Medicare Shared Savings Program, to see if there's ways we can take lessons from the AIM program, the ACO investment model, which was popular in more rural and, areas and with lower volume providers, to see if there's lessons we could take from that model and transport back to the MSSP program. And then beyond that, we've got a new lead for our state and population health group, who is looking at ways specifically to enroll safety net providers, rural providers, and bring them into our model. So we have a concerted group that's thinking about what we might do beyond the payment adjustments that we included in this model here.
If I could just follow up, I mean, it's the size of that rural practice and the capitalization that makes shared risk less capable of being absorbed.
Mm-hmm.
And there's never a differentiation of that specific issue in your shared savings model.
Yeah, and the ACO investment model that gives upfront payments and lets providers take advantage of some of those payments up front may not be enough to overcome that hurdle, and we recognize that. We did have the chart model that was looking at rural. There was a state-based, community-based arm of that model, and then the chart ACO model that was specifically targeted to rural areas, and it's that we recently announced that we're not going forward with the chart ACO model and instead looking to see whether there's lessons that we could incorporate into the broader MSSP program. It won't be an answer for everybody, and I think we are very interested in input, so I think if you've given it some thought and have ideas for us, I think we're very open to that.
Hello, Bruce Landon from Boston. So I'm also really delighted to hear finally an ACO program that's acknowledging the importance of primary care for making these work, and one that's really incorporating and melding some of the primary care models and ACOs. I have one very kind of specific wonky-ish kind of question and then one more general question. The specific one, so when you mentioned the beneficiary enhancements, a lot of them look like they're in the primary care space actually. And I'm wondering why the thought wasn't given to sort of just trying to incorporate that into the primary care capitation payments. Like when we look at a lot of the payments that have been enacted over the last 20 years that are supposed to enhance payments to primary care, basically no one uses them because they're too complicated. So and this sort of seems like it's going in that direction a little way.
That's a very good question, and I'll let you take the wonky one, and then there's like a general one that I might be able to answer.
Yeah, and I just want to make sure I'm clear. So are you talking about the benefit enhancement specifically, or?
Yeah, there's like home-based visits and stuff like that after discharge. Like a lot of that I think of as potentially in the primary care space.
Are you saying why is that in the general benchmark instead of in the primary care capitation?
Why is it a different beneficiary enhancement that's going to be paid for separately than in the beneficiary than in the capitation? Is what it sounds like it is at least.
Oh, sorry. So yes, the capitation is really addressing all of their Medicare expenditures, right? Depending on whether they're doing primary care capitation, which is one mechanism, right? Or total care capitation. The benefit enhancements are applied feed into their Medicare expenditures. So to the extent that it's regarding a primary care service, it will be included in the primary care capitation versus if it's otherwise, it would be included in the total care capitation.
So it is included? Does that answer the question?
Right. It's not pulled out as it's not pulled out as a separate expenditure from their general Medicare fee-for-service expenditure.
Yeah, truthfully, I mean, if you're capitating primary care, they should be able to do whatever they want in terms of a benefit expansion or whatnot. That being said, so let me move on. So the other question is about the quality measures. So let's just leave the patient experiences on the side. So if you kind of squint your eyes and look at them sideways, they sound a lot like other payment, spending measures. I mean, the most expensive thing that we have in Medicare patients is hospitalizations, and at least 2 of the 3 of them were basically preventing hospitalizations. So I'm wondering sort of what the thinking is in that area.
In terms of the selection of the quality measures?
I think we were looking to see which measures would best reflect where there's some reduction in unnecessary or inappropriate care, and then also that there's as a way to kind of see if they are improving quality of care. Unfortunately, we don't have our quality experts here, so
I mean, I will say it reflects a lot of the quality metrics that we're using in other models. Is it the accurate reflection of what's actually quality of care? I'm not, I think we can all.
Let me rephrase it. So supposedly under capitation, you have pretty strong incentives to reduce care. So that includes reducing low-value care, reducing hospitalizations and whatnot. But there also might be incentives to reduce, necessary important care and stinting. And it seems like measuring the same thing that you're already trying to reduce under your capitation model is not really sort of guarding as much against stinting.
Mm-hmm. I mean, I guess I would say that we are looking at the potential for stinting and measuring whether or not we think it's happening, or whether it's low-value care. I think we'll have claims data and we'll be able to measure that. It's not what we're identifying as here's the metrics that we're including in the set of quality metrics, but we will be able to look at some of those changes and patterns.
Yeah, one of the things under ACO REACH that we are doing, just in response to some of the feedback we've heard, is really taking a much more extensive look at what's happening in terms of monitoring the claims data and the beneficiary experience and the quality. And so, as Liz said, I know we have something on our website you can show, but we're looking at a lot of that, like doing a lot of analysis to really look for care stinting and monitoring how care is being used and affected by those mechanisms. But I think we're always open to hear thoughts about other measures. It's kind of a delicate balance between reducing the number of measures, right, but still make sure that we're really capturing a good picture of what is improving or impacting the quality of care that the beneficiaries are receiving.
I mean, maybe there's a difference between the quality metrics that could potentially impact payment and the other things that we're able to look at whether or not we're making a difference based on the claims data.
Right.
But those just aren't necessarily the ones that are influencing the payments.
Yeah.
For purposes of the 2% withhold, in other words. If that makes sense. Like, you want to make sure that those are legitimate, validated metrics. We will have the ability to look at the claims data for some of the other items that and measures that you mentioned.
Hi, I'm Catherine. I'm from GovCIO Media and Research. I was curious about the health equity data collection requirement you mentioned, which you said was looking for demographic data and social determinants of health. And I was wondering what you see the uses of that data being and how you hope to respond to it.
Right. So I think we want to do the data collection to make sure we have a more complete data set that reflects what the beneficiary's perspective of those needs and status. And we're collecting it to really monitor, right, to understand how our models are impacting the different subsets of beneficiaries in different populations, and to see if we're really achieving equitable care. I think also we're looking, this is kind of a stepping stone to see, as we collect more and more of that data across the center and the agency, to really be able to have a better look at what's happening health-wise across these different populations. And so,
yeah, I would just say when we look back at our models, if we're improving quality, are we improving quality for everybody, or does it only affect some groups? And I think collecting this data will be able to give us the ability to say whether we're improving quality or impacting quality based on some of these factors, which we have sometimes been able to do, but not always when we haven't collected the data. We're just going to try to do it on a more standardized basis.
yeah. And I would add, it gives a window for the REACH ACOs as well, so that they can see within their population the impact that they're having as well.
Any additional questions?
Hi. First of all, thank you for your public service. I know it's very hard work. Really appreciate all of that. And this is a question beyond the REACH model, actually, like much more like broad, almost like sort of meta question. But so much of the work in healthcare transformation is about integrations with the community. Meanwhile, lots of federal agencies have been like working with the community for some time. I'm thinking about like your HRSAs, your SAMHSAs, ACFs, even like HUD, in the form of their HMIS systems. So work on the ground is about integrating those systems, sort of integrating those communities and those conversations. And I'm just kind of curious as to what that might look like from the federal perspective. Are you in conversations with HRSA, ACF? I know you are to some extent, and HUD, USDA has like WIC and SNAP benefits. Just some perspective on like what integration at the top, starts to look like, so that it trickles down into the community.
I think that's a really good question. And I think this administration, and I served in the Obama administration as well, and now back in the Biden administration, has really put a priority on social determinants of health. And doing that really requires those partnerships. We just had a meeting at the leadership level with ACL 2 weeks ago to figure out, okay, this is what we're doing. How can we take advantage of the area agencies on aging, for example? How can we look at what you're looking at the home and community-based level? Is there some intersection here where we can learn from or borrow from your relationships and the work that you're doing? We're having similar conversations with SAMHSA on mental health. We're talking to HRSA on a regular basis, thinking about rural and I think figuring out on the rural side as well as on the FQHC side. If we want to bring FQHCs into the programs that we're running, we're figuring out that they have a very different payment mechanism than other providers, and we don't really understand them because they're run by HRSA. So until we have those conversations, it's it's more likely to be successful if we work together. I think we're also looking across departments as well, and so the Secretary has asked us to start thinking about working with HUD, for example, on housing, and making sure that we're having conversations there as well as the Department of Agriculture. So I think those conversations are happening at maybe a level that they hadn't in the past, and it's really encouraging. But I think if we're going to make a difference on social determinants of health, that's exactly what we need to be doing.
Yeah, I appreciate that. And I don't want to put you on the spot, but do we anticipate like future models way down the road incorporating like braided funding streams and like really bringing some of these other agencies into the forefront?
That's a harder question to answer. I mean, ideally, look, I'd say we're, even within CMS, sometimes you end up in your own silo. We're trying to break down some of the silos even within CMS, so we're doing a lot more work with the Center for Medicare, making sure that even the programs on ACOs work together well, that their incentives in the Medicare Shared Savings Program don't interfere with ours and vice versa. So we're trying to do that at the agency level and braiding those funding streams and thinking about them consistently. I think we'll make our way out of concentric circles and start thinking about that. But I think there's so much more we can do together and be more effective and efficient if we do exactly what you're suggesting.
It's a big government.
Yes.
Totally get it. Yeah, thank you.
Well, if there aren't any more questions, our door is open. Megan gave some websites. I don't know if you could probably go to the CMS Innovation Center website and find all of the REACH materials. We welcome your input. I think we have really put a priority on trying to make sure we're listening to people. So if you have ideas for us, we're open to them and really appreciate your coming and listening. Thank you.
Thank you.